So the question that has been asked is enumerate the various positions in relation to anesthesia and discuss the problems associated with them. So various positions, you can classify them into main 5 positions only: supine, lithotomy, lateral diabetes, prone and sitting. And whatever the other things we said about Trendelenburg, the lawn chair position, the frog leg position, all these things are modifications of supine position only. So the patient's back will be completely on the operating table. Whereas in other positions, lateral diabetes, patient's side will be in the side, bone he becomes completely turned out, and sitting it becomes partially away from the table. So this is the lawn chair, the frog. I think Yoga, did you mention about lawn chair position?
No, sir.
No. So that is one of the modification, and frog leg position. Of course, these are not very commonly used. Of course, lawn chair is a very common procedure. I mean, position Trendelenburg and reverse Trendelenburg, they are modifications of that. So this is the common supine position. All of you will be very much aware of. And here you can see the patient's upper limb is by the side of the body. Normally, we try to keep it abducted at the side majority of the time, but in some cases it will be by the side. So these are all the common pressure points where patient is going to lie down for several hours for the surgery. These are all the pressure points where compression can produce. So occiput, scapula, thoracic vertebra, sacrum, coccyx, calf muscles, calcaneum, olecranon. So this is the problem with that. And the Trendelenburg and reverse Trendelenburg are done like this. Trendelenburg is head steep, head down, and reverse is head up position. So these are the positions that you are aware of. And this is what is called the frog leg position. Okay? So this is the these are the 3 modifications, I mean 2 modifications, or rather 3 for the supine position. And I will show you the benefits and so in your answer paper, you can write like this: supine position, what are the cardiovascular effects, respiratory effects, nervous system. Of course, not central nervous system, the peripheral nervous system will be. Even in central nervous system, you can say about jugular venous flow, jugular venous return, CPP, the CSF drainage, all these things, whether it will be affected or not. And benefit and rest will be easiest position, and often needs head flexion, extension, rotation, ulnar and peroneal nerve injury. So, just like bullet points, if you write all these things, you will be able to complete the answer in a faster time. So, the common things that get affected in changing the positions are CVS, RS, and nerve injuries. So, arm position during supine has to be either by the side or abducted. When you do the abduction, you should make sure that it is not below 90 degrees. So hyperextend that will produce a stretching on the brachial nerves, and that will cause problem. And the lawn chair position, which is used, usually relaxes the hip and knees and better tolerated, especially when they are under monitored anesthesia care. So you know how to put this patient in lawn chair position, Shobha?
No.
Okay, I will show you the picture now.
Okay.
It will reduce the tension on the abdominal muscles and also help to close the wound. In frog leg position, when you put that the feet together, the sole of the feet will be touching each other. You have to take care of the hip joint as well as the knee joint. Okay, very important. Possible nerve injuries when you put the patient in supine position is too much of rotation of the head will cause stretching on the brachial plexus. Too much of abduction will cause the axillary nerve compression or stretching. And forearm pronation will put the pressure on the ulnar nerve. So these are the 3 nerves that can be injured. And this shows varieties of supine position. This is a classical with the arm abducted by the side, and how you support the arm. The palm surface should be always facing the ceiling or the roof of the theater. Otherwise, it may be in the neutral position. Never put the patient's arm in the prone position. And when you put the arm by the side, the draw sheet should be under the patient's body, not under the mattress. Make sure that it is not under the mattress. It should be only under the patient's body, and you tuck it under the patient's arm. This is called the lawn chair position. The D, what you see here is the lawn chair position. There is a slight elevation of the leg and the slight bending at the knee, so that you can put a pillow underneath and then give a support here. This is much more comfortable for the patient. And this is the Trendelenburg and reverse Trendelenburg. So here, the A position is the normal supine position that we normally use. And the B is the how you keep the arm on the arm board. And C is the arm tucked under the patient's side. How do you do that? And lawn chair position is D, flexion of the hips and knees to decrease tension on the back. Trendelenburg and reverse Trendelenburg. Again, you have to make sure that prevent brachial plexus compression injuries as well as the other effects which she mentioned correctly. Then lateral position, again, compared to supine, anesthetize it, whatever cardiovascular system changes that happen, respiratory system changes happening, then the cerebral blood flow, peripheral nerves, brachial plexus injuries. So here in this picture, you can see the head is hanging down and the spine is not in alignment. So the correct way is to keep the spine alignment in a straight fashion like that. And this is the shoulder flap position with the little head up, and you have to give a support at the axilla when you put the patient in the lateral side, and the always the bottom leg should be straight and the upper leg should be slightly bent, and the pillow should be kept at the between the two. And these are the various questions. So this is how the the bottom leg should be bent and the upper leg should be straight, and the arm support. Most of you will be aware, especially MEAT students, while doing hip surgery, whether it is fracture or other position, this is the common position that you come across. This becomes the dependent upper limb. Okay, so you have to give padding and take care of both the things, and give a roll underneath here to keep the axilla free, so that there is no compression on them. So this is the lateral decubitus position. And prone position is adopted as the indications were told. And again, what are the changes that happen in the cardiovascular, respiratory, and changes, and the benefits and risks. And any name for this particular position? You can see the difference between this picture and this picture. What is the difference that you see?
Legs are raised up.
Legs are raised up here.
Head
Okay.
is-
What about the head?
Head has a pin.
Head is down.
So the neck and head is flexed here, hyperflexion.
Yes.
Okay. Whereas here it is almost neutral. So
Neutral.
what is this position called? If you flex it too much, it's called the chondroid position. Okay. This is like modification. And sitting position is the next one. So this is adopted mainly for the posterior fossa. These are all the changes that you see. Whatever she has described, she has done well. And these are the questions that you have to answer whether it is true or false. Lithotomy position may be associated with compartment syndrome, peripheral
Yes.
neuropathy, deep vein thrombosis, and injury. Which are all the answers which are true, which are the answers which are false?
A, B, C, true, sir.
All are true or all are false?
All are true, sir.
All are
true.
true. Correct. All are true.
Yes.
You can have compartment syndrome, you can have peripheral
Yeah.
neuropathy, you can have DVT, and you can have hand injury also, because the hand sometimes gets stuck between the table and the head. Then venous air embolism with a potential complication in surgery in the sitting posture. True or false again? All VAE can be detected clinically by decrease in end-tidal carbon dioxide. A decrease in
false.
oxygen
A is false, sir.
A is false. B,
False.
decrease in oxygen saturation will not always be seen, even with larger emboli. And VAE can lead to arrhythmias, right ventricular failure and
C
cardiac
is true,
arrest.
sir.
C true.
C is true. D is false.
Hmm.
B,
D, surgeon has no role in the management of VAE.
D is false, sir.
So D is true,
So
sir.
A is false,
So D is true.
is true. C is also true. We can lead to arrhythmias. Of course, you
Yes.
said true about that. And D is false. So the two answers that are correct are B and C. The last one regarding complications of patient positioning. Eye injury only occurs when patients are position prone. Supine,
False.
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 Correct.
Fetal position
Supine is the
also.
only position not associated with injury from pressure areas.
False.
False.
False. Cerebral ischemia can occur in the sitting position.
Sir.
True.
Sir.
True, sir.
Deep
True, sir.
frontal position may be associated with the development of airway edema.
True,
True,
sir.
True,
sir.
correct. So two false and two true, correct. Excellent. Now coming to sitting for deep chair problems, access to the airway will be limited and after surgical draping, so that makes sure that the endotracheal tube is well secured and always note the length and write it on this plaster that you put it on so that you know whether it has moved out or moved in. Hypotension is very, very common once you put the patient in sitting posture, so it has to be done in a very gradual fashion. Non-invasive blood pressure monitor should be placed in the non-operative side or not in the leg, especially during sitting position. Many anesthetists put it on the leg, should not be done. And if invasive blood pressure is done, the transducer should be at the level of the tragus of the patient, so that it will read the correct blood pressure. Apply padding to all pressure points, heels and ankles. Avoid excessive flexion of the neck in the sitting posture. Now, tendon problems are prolonged tendon can lead to facial lateral edema, which we saw earlier. Could be assessed for prior extubation with a cuff leak test. So, it is one of the indications. Normally, we do it under thyroid surgery, goiter, to assess the tracheomalacia. So here is another indication. Along the triangular position, you have to do the complete test. And minimizing the amount of intravenous fluid. And endotracheal tube may move caudal during positioning. So endobronchial intubation is possible. So these are the problems with early birth. We can reduce FRC and cause basal athletics, reduce the complaints. High airway pressures may be there. Barotrauma may happen because of increased peak airway pressure. And steep Trendelenburg patient may slide out of the table. So we must be carefully giving the support. And the arms must be secured to prevent falling. So usually they give a shoulder support, but make sure that it doesn't cause any pressure on the brachial plexus. And it will increase intracranial and intraocular pressure, the Trendelenburg position. So it should be avoided in patients who have glaucoma or other intracranial raised in ICP. And reverse Trendelenburg, the benefit is it will increase the FRC because the diaphragm is going down and the ventilation will be easy, lung compliance will be good. So you have to give larger lung volume. Hypotension may be the problem because the venous return will decrease. Hydrostatic pressure gradient between brain and cup will be more. And this is a person who, this is the way they did the lithotomy in the olden days to do the surgery. One person used to hold all the time the leg and then they used to operate. The original Trendelenburg position, then they removed that man who was holding by the adjusting the table in 1895. This is the steep Trendelenburg. This is the reverse Trendelenburg. These two are called Fowler's position and flight header built in the post-op period. This is Lloyd Davis position. This is another lithotomy, 90-degree lithotomy for anal surgery. This is hip flexion lithotomy with a wide abducted leg for gynec surgery. So there's a small difference how you do it for anorectal procedure and how you do a gynec procedure. And the problems of lithotomy are often combined with a little bit of Trendelenburg also, may exacerbate the respiratory problems mainly. and it may cause dislodgement of the endotracheal tube. When you do the change, so you have to be careful. Decreases the blood volume in the limb, redistributes this. So the complication which we already saw, neuropathies, compartment syndrome, venous thrombosis, and of course patient's hand should be taken care of. These things are usually the positions that you would have commonly seen for shoulder surgery, either in the sitting position or in the slightly lateral position. And this is what is this position? Can you identify? Can you see something here?
For renal surgery is very
Kidney bridge position. This is called the kidney bridge position. And this is the frog-leg position. What you see here, frog-leg position. And these are the prone position, head supporting prone position with the head frame A and B. And how the tube is fixed. This is a special fixator that is used for preventing the tube from slipping. Okay. So after we integrate, what we do is we introduce this fixator. This will have a strap, and you can. So this will hold the tube correctly in that position. So you can see the 22 mark here. So at that point you can fix that so that you can tie a tape and keep it. Because if you put a micropore, it may slide off because of the saliva that may try to come and loosen the plaster. So head support in a jelly bag. This is another way to prevent the pressure. So instead of keeping it on a hard surface, you have a special thing called jelly bag. So prone position with a head traction for cervical spine surgery, posterior approach. And this is another way of doing sitting position for posterior canal fossa. Two major concerns of this is hypotension because of PVH instability and venous air embolism during surgery. Okay, so these are the things you can think about for position in anesthesia. Okay, so remember the basic 5 positions and the long leads, the Trendelenburg, both reverse and normal Trendelenburg and the frog leg are all modifications of the 5. Okay, so 5 plus 4, 9 things you have to write.
Yes, sir.
Right. Shall we go for the next question?